to all. Today, as Arun said, today we are going to learn about the gastrointestinal symptoms, part 2, that is on intestinal obstruction. This is one of the common problem in patients with abdominal and pelvic malignancies. So this session will be taken by Dr. Vineetha Rijju, who was our last week faculty. Madam, welcome back and over to you. Madam, please unmute yourself and talk.
Sorry.
Okay.
Yeah. Hi, everybody. How are you all? So we are here with the part 2 of gastrointestinal symptoms. So many of the things what we learned in last class is going to help us a lot when we are going to be dealing with today's topic. Okay. So let's just get on. I shall try to share my screen. Give me a minute. Yeah. Is that fine?
Yes, ma'am.
Yeah. Right. So today's topic is bowel obstruction. So we dealt with nausea, vomiting, constipation, all that in last class. So today we are going to see particularly in bowel obstruction. Right. So what I intend to do today is basically we shall go through the classification of intestinal obstruction. We shall see what are the symptoms that we come across in intestinal obstruction, how to diagnose it. When you have a patient in front of you, how do you actually diagnose that, okay, this person could be having one, management, and again, treatment and palliative care. So before I move on to the slides, let us just have a random kind of exchange of ideas about, okay, what do you think are the different types of intestinal obstruction? I mean, when you talk about intestine getting obstructed, have that picture in your mind. And what could be the different types here? You can unmute yourself. What all could be the reasons? I'm sure you've seen patients with intestinal obstruction. So what do you think can be the different reasons? I mean, we need not be, particularly mentioning the different entities under the classification, but you can always give me your ideas on what could be the different reasons for intestinal obstruction. Come on. Is anybody on the chat giving me the answers?
Yeah, ma'am. One chart is hernia, blunt trauma,
right.
then tumor mass or impacted stool.
Right. Yeah.
Severe constipation.
Mm-hmm. Yes, I got the chat screen. Yes, blunt trauma, any growth,
Yes.
severe constipation. That's wonderful. You've got many answers here. And so exactly. So you have something where you have a mass or something over there actually which is obstructing the lumen. And if there is no particular obstruction as such, can it still cause bowel obstruction? What do you think on that? If there is no mass or any foreign body or any compression from the top, do you think there can still be an obstruction? There is no growth, nothing. Yes, definitely. A decreased peristaltic movement. When there is no actually forward movement of the colon, which we call as peristalsis, that itself can lead to a situation which we say is intestinal obstruction. So now what are the symptoms that we come across? Symptoms? Yeah. Abdominal pain, right? Tenderness, yes. One hand on the abdomen and they would just probably yell, right? Correct. Constipation, very good.
Abdominal
Vomiting,
distension.
yes. Yes, that's very nice. We have so many answers coming up here. So definitely it is abdominal pain. It is abdominal distension. Then you would have constipation. You would have vomiting, decreased bowel sounds. They're just getting much better here. Our answers over here are just getting much, much better. So with all that, how do you diagnose it? How can you diagnose that, okay, your patient, the patient right in front of you has come with a couple of these symptoms over here, two of the symptoms over here. So how can you actually tag them as intestinal obstruction? CT, ultrasound, X-ray.
Abdominal extension.
Yes. So we have a whole lot of imaging modalities, one after the other, just coming into the answer chat screen. So definitely, I really appreciate everybody being very proactive today. That's exactly how I would want this discussion to go forward. Right. So now comes the management. How do you think we will manage them? It's nice to know how much we know, because by the end of the class, it makes a huge difference when you go back to it and you realize how much you've gained new knowledge in the end of the session. That's why I'm just trying to get the best out of you over here at this junction. Okay. So how do you think you're going to manage these patients with intestinal obstruction? What have you usually seen? Surgical, yes. Removing the mass, you have a mass which is causing the obstruction, so definitely it's probably surgery. You have to take off the mass. Stool softeners, yeah. If you're going to be dealing with constipation, definitely. We had a class on constipation, right? So stool softeners, other laxatives, painkillers. Again, Parvati has said painkillers. That's really nice because these patients are going to be in a lot of pain. Right. So having said that, now let us go to the next. So I will be going through this case report. This is the story of Sarah, and I will be going through this. This was taken from a journal article. It is a case report that was given. Just after our session, we will come back to this case report, okay? Right. So like you all said, what are the different types of intestinal obstruction? Some of you told that is probably because of a mass. Some of you told me it is because of decreased peristalsis. These are defined under the terms non-mechanical and mechanical. Okay. So mechanical would be all these things that you were talking about, like an obstruction, a mass, and things like that. And whereas decreased peristalsis would follow under non-mechanical. Okay, rather otherwise called as functional obstruction. So under non-mechanical, you have the functional obstruction, that is a paralytic ileus. Now the paralytic ileus, it can be because of various reasons. It could be even because of commonly seen electrolyte imbalance. Commonly seen electrolyte imbalance, which can cause decreased peristalsis. Do you know which one it is? Do you know? Sorry, I got to the next slide by mistake. Yes. Calcium? To an extent, but I'm looking for another very common one. Which could that be? Sodium? Okay, the answer is potassium, okay? It's hypokalemia, which could result in hypokalemia, that is low potassium levels, which could cause functional obstruction, right? So it is important to actually think also about other reasons other than just mechanical when you are looking at a patient with intestinal obstruction. So coming on to mechanical, again, the mechanical obstruction is further classified. Okay, it is further classified according to its pattern, way of presentation. You can actually even get an idea of what clinical condition it is, or where exactly the obstruction is uh, by taking the history of the patient, or by examining and just looking at the abdomen. Sometimes you can get an exact picture of where the obstruction is, and even all the set of imaging modalities that you were talking about, x-ray, ct, ultrasound, maybe all these are sometimes not even required. You can do this even at the home setting, at the bedside home setting of a patient. So dynamic obstruction or mechanical obstruction can be further classified into the speed of onset. Sometimes it can be acute, sometimes it can be chronic. Yeah, like how you were talking about, chronic constipation, and this chronic constipation leading on finally to a acute on chronic. Okay, so that would be what we would expect for an intestinal obstruction for a in case of constipation. And sight. This obstruction can occur anywhere, right? It can occur in the large bowel, it can occur in the small bowel. And it's very interesting to note that by the symptoms that the patient is telling you, you can actually make out where the obstruction is. And we will be coming to that, okay? And so it's again based on the site, small bowel, large bowel, and the nature, that is simple, closed loop, or strangulated. Okay, those are the different types. Patterns, what they associate, what they show up with. And etiology, where, how is the obstruction, where exactly is the obstruction, whether it is an intrinsic or extrinsic obstruction, or is it an intraluminal, whether it is inside the lumen. So we'll just look a bit more on that. When I was talking about simple, what I meant is that there is one obstruction there, but there is definitely no vascular compromise. In a closed loop, what I mean is obstruction at 2 points forming a loop. And what happens is that there is 2 obstructions, and the middle part is definitely grossly distended. Okay, now what happens when the 2 ends are pinched and it is obstructed and you have a very dilated part here? Definitely after a point, there is further distension going to happen there, and it perforates, right? Yeah. So this can be seen in volvulus, and that's a condition. And again, now when I was telling you in the first simple that the blood supply is not compromised, but what happens when the blood supply is compromised? When the blood supply is compromised, it's an ischemic kind of pain. That's what we call it, ischemic kind of pain. The pain is much sharper and it is more localized, right? And there is also what we term as peritonism. And the patient presents with fever, increased WBC counts, and also there are other signs of mesenteric ischemia, like a bloody diarrhea, things like that. So the bowel is capable of contracting normally or even excessively proximal to the obstruction. So if you have an obstruction here, the bowel that is there proximally to it, it is still capable of contracting. Okay. So we just went through what are the different causes of mechanical obstruction. That is intraluminal, like we all were just discussing before, like fecal impaction. That is one reason. Foreign bodies, bezoars, gallstones, these are all intraluminal, within the lumen. Now, intramural, within the wall of the lumen, that can be because of strictures that happen. What happens is that if a person has undergone several abdominal surgeries, what happens is that there are adhesions formed. There is a kind of gluing that happens with the soft tissue adjacence of tissues. So this will lead to a situation which is known as stricture. That is, a lumen is compromised because there is a stricture that is formed. And again, intramural reasons, intramural obstructions are also one of the causes is malignancy. Okay, and extramural, again, bands, adhesions are reasons. Hernia, which was said by one of you, that falls under extramural. Volvulus, intussusception, all these fall under extramural. And again, now we have the adynamic causes. We talked about paralytic ileus, mesenteric vasculation, occlusion, and pseudo obstruction. All these things fall under non-mechanical or adynamic functional obstruction. Okay. Right. So you were telling me about patients present with abdominal pain and they present with vomiting, isn't it? So constipation. So how exactly is this happening? This flow diagram over here tells us exactly how this happens. Okay. So here you can read it from here. That is partial or complete bowel obstruction. When there is a partial or complete bowel obstruction, there is a decreased movement of intestinal contents. Okay, so if you have a partial or complete bowel obstruction, like I was saying before, there is an obstruction here, there is still the bowel movement happening, the peristaltic movement happening in the proximal part. Now, when there is a peristaltic movement happening still continuously in the proximal part, this leads to colicky pain. Okay, this is what leads to colicky pain. So the waves, the peristaltic waves that come and they reach the obstruction point, they get augmented by the peristaltic waves that follow them. And so definitely it's a much higher contraction that comes, and which in turn causes a lot amount of pain. So the typical nature of the pain is colicky pain, a gripping type of pain. It comes and then it slowly weans off, and after just a while again it comes. So that's a colicky type of pain. Now, again, what happens is that in a partial or complete bowel obstruction, there's a decreased bowel movement contents. I mean, there's a decreased movement of the bowel contents, and this further leads to bowel distension. Okay. Now, it is not just the bowel contents which is causing the bowel distension, but also there's a lot of bowel secretions that is happening. There's a lot of bowel secretions happening because the gut epithelial surface area is getting increased because of the distension. So all this in turn, they cause more and more of bowel distension. Okay, now what happens when there is more of bowel secretions and bowel distension happening? This causes nausea and vomiting. Right? Now, when there is a whole inflammatory response happening in the epithelium of the bowel, this in turn also causes bowel mucoepithelial damage, which in turn causes increased pain and a more continuous kind of pain. So that's how the symptoms are caused. Okay. Right. Sorry, it's not moving. Okay. So as I was saying before, the level of obstruction determines the pattern of symptoms. So what happens if you have an obstruction higher up in the small intestine? Have you seen it during practice? For patients who have an obstruction in the small intestine, and for those patients who have an obstruction in the large intestine, have you noted anything, any difference? Yes. Anybody? Okay, so generally what is seen is
Small,
like, yeah.
Small intestinal obstruction present more with the vomiting and
Yeah, correct. Yeah. So those patients who have an obstruction in the small intestine, they present with more of vomiting. So they would give more symptoms saying that, I'm vomiting all the time and there is so much of vomit coming out. I'm hardly eating, drinking anything or eating anything. I don't know from where all this vomit is coming. Very typical wordings of patients. Okay. And large bowel obstructions, they basically come with a history of decreased bowel movements and abdominal distension more in that. So why is it that there is more of high volume vomit in the small intestine obstruction that is seen?
most of our absorption and everything happens in the small intestine.
Mm-hmm.
Well, like passing on to that side, no, ileum and jejunum ileum.
Yeah. Okay.
Maybe that's the reason. I mean, I'm just.
Could there be more reasons? Because there's a lot of fluid content there.
Yeah, and the
So
ileum
what is the difference in the large bubble? Yeah.
Hello.
Yeah, I can hear you. Could you
Hello.
repeat that? You were saying something? Or you want to type that down? Yeah, you were saying, like, the discussion was there is more of vomiting in the small intestine obstruction. But what is the reason? It's just that normal physiology of small intestine and large intestine.
Most of the absorption part is happening in the
What absorption?
I mean the water content and everything. I mean
exactly. That's just the answer that I wanted, because generally what happens in our digestive system is that the more of water absorption is happening in the large intestine. So there's still a lot of volume of fluid content when the transit is happening in the small intestine. So that is why when there is an obstruction in that level, there's more of high volume vomiting that happens. Okay. So what happens when there is a complete obstruction? Complete obstruction, what would the patient be telling you? What would be the symptoms that the patient is telling you? Yeah. What would be the symptoms that the patient is telling you? You can just repeat most of the symptoms that we already did previously. I just want that couple of things that could be, just repeated. Heaviness in the stomach. Okay. Heaviness in the stomach. Abdominal distension, fullness. Yes. Wonderful. Yes. Constipation. And what about that constipation? I would like to catch on that. Constipation. See, constipation, we are talking about anything, right? It is a change that is happening in the regular pattern of the bowel movements of that particular individual. If a person goes like 3 times a day regularly, if he says that I am going only once daily, that is constipation for him. That's what he calls as constipation. But what are we talking about? Complete obstruction.
Not going for today.
Yeah. There will be absolutely no bowel movement. Okay. In complete obstruction, not passing stool daily, and you will have to ask back how many days has it been since you have had any bowel movement at all. and there has not been passing of even flatus. There is no passing of air either. Okay, so that is very typical of complete obstruction. Okay, so these are important signs that you need to know, because even when you are treating the patient, this is how you are trying to measure whether the treatment you have given has actually started working. So like if you're treating the patient with certain pharmacological agents and we are following up the patient daily, there are some questions you have to ask to understand if it's been working, if the drug is working for the patient. So asking the patient, have you passed motion? Or before even the motion being passed, have you passed flatus? Have you passed air? If you ask questions like that and the person has gained some amount of peristalsis, this could be one of the first things that the patient tells you yes. Okay, and then you know your management is helpful. Now there is also spurious diarrhea, right? So what was spurious diarrhea? We just discussed it in our constipation class last week. That is also possible to be seen in complete obstruction. What was that? Spurious diarrhea? What was spurious diarrhea? Is it because the person has diarrhea? Is spurious diarrhea exactly a diarrhea? No. Yes, that's not. It's not diarrhea, right? So what is it a part of? When you say spurious diarrhea, what is it a part of?
It's overflowing in the constipation is there, and behind
Just
that,
overflowing. Yes.
Overflowing of that.
Yes. So that's what it is. So as part of prolonged constipation, when the patient develops an overflow incontinence, that is when we term it as spurious diarrhea. So that again could be seen in complete obstruction as well. Okay. Yes, so we have answers here from many of you all. Merlin has said fullness, Dixita has told constipation, Kiruba has said severe abdominal pain. They're all right. Okay, that's all correct. So now moving on to the next slide. So now you need to diagnose. Okay, so you kind of have a picture. You've examined the patient. So when you examine this patient, you did tell me the patient is going to have tenderness, right? So what other features are you going to see in this patient? Now, this is investigation. This diagnosis over here is investigation. So please tell me what you think will make you feel probably this patient does have mechanical obstruction, or let's put it as mechanical obstruction. What is going to tell you that this patient has mechanical obstruction when you examine the patient? Yeah. Either on chat or you can tell me. You're standing right in front of the patient and this will help you understand. Yes, image of the impacted stool. Okay. Now that is investigation, right? You have to do an imaging, right? But before going on to the imaging, imagine you're at a home setting, you're at the bedside. So what do? You don't have any X-ray machines there. You don't have any ultrasound. You don't have any CT machines. What are you going to do? You look at the patient, right? Look at the patient and check how much pain the patient is undergoing. With you look at the patient continuously, and sometimes you can even make out that the patient is having. Yeah, you ask for history. You ask for a complete history. And what kind of pain are you looking at? You are looking for. You see that the patient is suddenly wincing in pain. It's a
Working time.
Yes.
Colicky pain.
Correct. So we are looking for a colicky type of pain. So when you're looking at the patient is an immense amount of pain, and slowly, gradually, you can see the pain wean off. And again, in a matter of a minute, again, the patient is gripping back in pain. And that's so typical of colicky pain. A patient may be a bit pale because of the pain. And what else? When you're looking at the abdomen might be distended. Kiruba has said abdominal distension. What else? You're looking at the abdomen. What else will you see there? Anybody? You're looking at the abdomen. No peristalsis. Okay. Any other answers? Tenderness. Okay. But tenderness, it's a little beyond looking, right? After looking, you palpate. When you put your hand over the abdomen of the patient, and at that particular point, he winces in pain, right? So that you are able to localize, and that's what we call as tenderness. It is something that you see on palpation. When you're looking at the patient, what do you see? Yes, distension. Mellon has also said distension. What else is there? Like, I'll give you a clue. This is something I told you even before. When there is an obstruction, the bowel which is there proximal to it, there is still peristalsis happening over there.
Ausculted sounds, ma'am.
Pardon?
Sound, the auscultation of bowel.
Yeah,
Sir?
you know what? In severe bowel obstruction, sometimes you don't even have to auscultate. Because auscultate, you have to put your steth on, and then you have to put the diaphragm on the abdomen, and you can hear the bowel sounds. And they are loud bowel sounds, and we call it Borgagni bowel sounds. Okay, but this, you can even see it, you can even hear it. Sometimes you even hear large vowel sounds, loud vowel sounds, and sometimes you can even see the peristaltic movement. You can even see the peristaltic movement on the abdomen. So when you see a patient, you are having your doubts, always look at the abdomen, look at the patient, look at the abdomen, feel the abdomen, and these are three things which will help you come to diagnosis other than the history taking. Okay, so after that we come on to diagnosis through imaging. So by and large, we diagnose intestinal obstructions by doing a erect abdominal X-ray. And by taking an erect abdominal X-ray, what we see is a very classical picture of, what is this picture? What is that typical feature that is seen on this picture? Anything that you see here? Do you know what it is usually called?
Abdominal X-ray.
Yeah, it is an abdominal X-ray, and you know, this is an abdominal X-ray of a intestinal obstruction, right? But there's a very typical feature over here, which I would like you to just understand. You know, these little air shadows that you see in the abdomen. Do you see that the bottom part of it is like a straight line? Did you all notice that? The bottom part of that air-filled gray areas in the abdomen, the bottom is just like a straight line, like as if you've taken a ruler and just drawn a straight line. That is very typical. That's what we call as air fluid levels. Okay, air fluid levels. So this seeing air fluid levels in the abdomen on in an abdominal X-ray, that in particular the erect abdominal X-ray, is very typical of bowel obstruction. And again, other than that, you can also do contrast radiography. You can with the help of gastrographin, and generally they do not recommend barium because barium tends to accumulate and is not easily absorbed. So further imaging, it might give a very distorted picture. So gastrographin is more used, and apparently it also helps in relieving the reversible obstructions. Okay. Right. So now coming on to planning and management. So how are we going to manage patients with bowel obstructions? You told me stool softeners, laxatives. What else? What else are we going to use? You told me stool softeners, you told me laxatives. What else are we going to use for bowel obstruction? Right? What is that?
Painkiller.
Yes. Earlier also you had mentioned painkillers. You had also mentioned a surgical intervention. I remember that. What else is there? Painkillers, because the patient is in a lot of pain, right? And what type of painkillers are you going to use?
Colicky pain.
Yeah, for colicky pain, right? So yeah, you had the pain class. So what type of medications are we going to use for colicky pain? Antispasmodics. Good. Now, the patient is in pain. The patient has bowel obstruction. So to address these two things, you told me analgesics for relieving the bowel. You have also suggested soft. Sorry, I didn't hear you. Could you come again? Okay. Cyclopam. Yeah, cyclopam, buscopam. Any of these things would definitely help with the colicky pain. And other than that, you also told me about stool softeners, laxatives. Okay, so now what else can you use here? What other pharmacological drugs have a role? Tramadol. Okay, tramadol also. Probably the patient has not just a colicky type of pain, but also has a continuous pain, nociceptive pain, where you would like to give the patient a analgesic for the continuous pain. And there you have the choice of using weak opioids or strong opioids. And when you choose your drug, for your analgesic, just make sure that you are going to give an analgesic which does not have too much of constipation as its side effect. Okay, right. So paracetamol, okay, that's also good. What else? Think about the different symptoms of bowel obstruction. Pantoprazole, okay. So think about what are the different symptoms of bowel obstruction and what are the drugs that you can give. Perinom, okay, you're telling me metoclopramide. Kiruba just said metoclopramide to control the vomiting. Ondansetron, again, that is to control the vomiting. So which one will you like to give? Will you like to give ondansetron that goes and acts in centrally to control the vomiting, or you want to give metoclopramide which will go and act on the D2 receptors of the bowel and promote the peristalsis? Which will you want to give? Perinom. Right. So keeping NPO, surgical intervention, ondansetron. Okay, lovely. These are answers by Jessie. Okay, my question is now, what would you like to give? Is it ondansetron or is it perinom when you have an obstruction? So I got a few answers over here. It says Marilyn, Kiruba, Diana, they all have said perinom. Parvati also says perinom. So definitely you would like to have some amount of, am I audible?
Yes.
Yes, ma'am.
Okay. Okay. I just got a message saying that my internet is unstable. Okay. So definitely you would like to go for an antiemetic which has a peristaltic forward movement. Which promotes the forward peristalsis for a patient who has obstruction, a bowel obstruction. But what if it is a complete obstruction? What if it is a complete obstruction and the metoclopramide you are giving is promoting the peristalsis and it's going, hitting the obstruction point, and then it just augments, and probably it is going to worsen the colicky pain. So check for pain, check if it is a complete obstruction, check if it is a reversible obstruction like just a chronic constipation which has led to a bowel obstruction. So if it's a constipation that has led to a chronic obstruction, a bowel obstruction, your peristalsis is the right choice. But if you have a complete obstruction, you have a tumor growth there which has completely obstructed the lumen, and your metoclopramide is going to cause further peristalsis and worsen the pain. So if you feel your patient, when you're reviewing the patient, your patient is complaining of more pain, stop the perinorm and choose another antiemetic. Okay, right. So any other drug, say suppose it is a tumor, it is a tumor growth that has gone and obstructed. Anything else? Any role for corticosteroids? Have you seen dexamethasone being given? Anyway, we'll just see. Okay, so when you have a patient who comes with symptoms of bowel obstruction, do a clinical assessment, do a radiological assessment, and then comes your decision making. Now what to do further? You've assessed this patient has got a mechanical obstruction. Now what to do? Now decide your treatment based on certain factors. Okay, patient factors, disease factors, two entities. Okay, right. So you have the two entities. Make your decision based on the patient factors, on the disease factors. What are the patient factors? What is the age of the patient? Is the patient an advanced age patient, like a very elderly person of poor performance status? Again, I'm telling you, age is not a factor. It is the performance status of the person that you have to take along with the age, and then make your decision. Okay, there are still very healthy 80-year-old people around us, sometimes even much healthier than all of us. Okay, so age, performance status, stage. If it is an advanced stage, maybe we might not go in as aggressive as we would do for a person who is on a second stage, right? Then future of anti-cancer treatment options. So if the patient has having a third stage cancer and is undergoing chemotherapy, and in between the treatment phase, he or she has come with an obstruction, and the question that has come to you is that should we go for a surgical colectomy or a colostomy? Yes or no? Yes or no? Patient is having a third stage cancer, undergoing chemotherapy, and the decision is, should we go for a surgical intervention, or are we just going to think it's a third stage cancer, so how is he going to benefit of it? Yes, so I have answers here from Parvati, Kiruba. They all say yes, it is needed. Jesse also says it is needed. A temporary ostomy is needed. It's wonderful. So if it is going, if you're in the course of the treatment, if the patient is in the course of the treatment, so definitely it does have a very good role other than end stage patients. And if the patient is malnutrition, is having malnutrition, or is having cachexia, again, you have to think twice. Concurrent illnesses, if the patient has a lot of other comorbidities, again, you have to take a second thought on your decision making regarding surgical intervention. Now, these are the patient factors. What are the disease factors? The extent of obstruction. If it is just one level obstruction, okay, you can just resect out the obstructed areas and probably take out and put a temporary ostomy, do things like that. But what happens if it is a multi-level obstruction? There's not actually much you can do. So site, proximal bowel or distal bowel, all these things also make a difference. Okay. Generally, proximal bowels, even if you put an ostomy, there is a lot of secretions coming out from small bowel ostomies, and it is very difficult maintenance also. Then etiological, functional versus mechanical. Again, that also helps us to decide. Then ascites. Generally, those patients having ascites who require very frequent paracentesis or ascitic tapping, they are not recommended for surgical procedures. Okay. Carcinomatous peritoneum, where the entire peritoneum is studded with deposits of cancer. Even then, it is unlikely that the patient will benefit. Okay. So basically, it all depends on the degree of invasiveness also of the tumor, and whether the patient is healthy enough to go in for the surgical procedure. So you can assess by doing endoscopy or an interventional radiology or even a laparotomy to see what is the situation, or a laparoscopy. Okay. So these are just some of that we already went through, whether it is an advanced age or widespread tumor or ascites. Ascites, in an ascites patients, you also see low serum albumin levels. So in those patients, there is always a tendency for further recurrence of ascites. Severe nutritional deficiency, palpable abdominal mass, previous radiotherapy to abdomen and pelvis. How does that affect previous radiotherapy to abdomen and pelvis? Because what happens is that these patients will have more of adhesions in the abdomen. Okay. History of combination chemotherapy. So, which shows that the disease is a tough disease when the patient has got a lot of combination chemotherapies before. So it shows that the patient has generally a poor prognosis disease. So then multiple sites of obstruction, poor peristalsis due to diffuse carcinoma peritoneum, and poor performance status. All these are factors where we think that, okay, this person is the one who we have to go only for conservative management. So treatment, most of you already answered these. You told me about laxatives, corticosteroids, antiemetics, anticholinergics, somatostatin analogs. These are anti-secretory agents. Somatostatin analogs are used as anti-secretory agents over here to decrease the secretions, bowel secretions, and thereby decreasing vomiting. Analgesics, again, we talked about it. There is also surgical treatment. There is also invasive procedures like NG tube insertion, gastrostomy, and colonic stent. Okay. Now, antiemetics, you told me metoclopramide or Perino, that is a dopamine antagonist. So you can start off with 10 milligram 8 hourly when you are giving IV or parenteral metoclopramide. Always keep in mind there is a chance for extrapyramidal symptoms. So keep a watch for that. And if your patient is tolerating metoclopramide well, only then increase the dose. Okay, you can even give it 6 hourly. Metoclopramide is one drug that can also be given as a continuous subcutaneous infusions, right, in a syringe driver. And again, the 5-HT3 antagonist, ondansetrons, can also be given. Prokinetics, domperidone, or metoclopramide, all these are given, but again, only in partial obstruction. Okay. So ondansetron, again, we have to keep in our mind that use it wisely, because ondansetron itself can cause constipation. Okay. Now haloperidol, it's an antipsychotic, but again, it gives a lot of relief for nausea and vomiting. You can start off with 2.5 to even 5 milligram in a day through a continuous infusion, or you can even give it, I start off sometimes even with 1.5 milligram every 8 hours and check for and review the patient and then check, change accordingly. Okay. Anticholinergics, yes, you did tell me about Buscopan. I start off with 20 milligram 8 hourly. And then it can also be given to as high as 120 milligram in a day through subcutaneous. It acts on the peripheral acetylcholine receptors. Okay, and only thing you have to keep in mind is that I had mentioned this in my last class also, to not combine anticholinergic with prokinetics. Okay, they nullify each other. Corticosteroids, yes, dexamethasone is what I was talking about. So generally when I have patients with bowel obstruction, what is generally done is that if it is a malignant bowel obstruction, to decrease the peritumoral edema, dexamethasone is advised. So I start them off from 16 milligram IV OD of dexamethasone to about 24 milligram once in a day. And this is given as a trial for 3 days. And the patient is reviewed every day to check for any change. So the only thing about it is that you have to see that you do not give the single dose of that dexamethasone towards the latter part of the day, because it can interrupt with the sleep of the patient, because steroids do cause some amount of excitement. So it can be given as a 3-day trial. And if it's helping and the patient has completely resumed his bowel movements, you can stop it. Or sometimes in selected cases, we taper it down and put it on a very minimal dose and then stop it completely. So if there is vomiting, definitely IV or sub-Q is the choice. And if vomiting subsides, you can change it to oral steroids. This is done for home care patients also. Okay. Right. So then I was telling you about octreotide. So octreotide also, I start off with 100 microgram 8th hourly. Or sometimes I start off with 100 microgram 12th hourly for patients and check if the vomiting is coming down. Or sometimes they might be having a nasogastric tube inserted, and there's a lot of secretions being collected in the bag, and the patients are started on octreotide, and the octreotide is increased to thrice daily according to the secretions. So it also helps to reduce the secretion, slow down the motility, and reduce the splanchnic flow, and increase the absorption of water and electrolytes, and has a potent anti-vasoactive intestinal peptide effect. So it can also be used as a preventive step apparently. Okay, depot preparations are also available, but generally in palliative care we usually give regular doses. Okay. Now it can be also combined along with steroids in carcinomatosis. Now the problem about using anti-secretory agents like octreotide over drugs like buscopan is that octreotide is very expensive. So try out other means like hyoscine, and if it does not work with that, always you have octreotide also. So in a nutshell, you have drugs, pharmacological management in bowel obstruction, like malignant bowel obstruction is basically with dexamethasone, metoclopramide, hyoscine butyl bromide, haloperidol. Of course, it can be combined along with opioids if the pain is still severe. And again, laxatives also can be used, such as stool softness. Okay. And this is stenting. This is just a diagrammatic representation to show how the stent actually works. It's a self-expanding metallic stent where it helps to relieve the obstruction. But again, it can be used as a palliative procedure. It's not a very highly intensive procedure, but still, it may not be actually beneficial for those with multiple level obstructions. Okay. So, and again, the golden rule is when your patient comes to you with obstruction, always do a rectal examination, check for impacted fecal mass, and always relieve the fecal mass digitally, and then continue with your managements. Okay. So these are the common FAQs that the patient or the patient family asks you, so doctor, what do you think? Should my sister or brother be hydrated? They're not having anything. They've been nil oral. So can I give oral feeds? Or what do you think about total parenteral nutrition? And sometimes they say, why don't you put a nasogastric tube, or why don't we just do a gastrostomy? So what do you think about hydration? Yes, hydration. How often should you hydrate? Can you excessively hydrate this person? Because there is nothing going in orally. So do you excessively hydrate this patient than what is required? No. Yes. Why do you say so? I agree with you. Why? Yeah, I have a lot of no's coming. That's excellent. But why do you say so? Can one of you tell me why you say so? Because it will increase the distension. Yeah, it is going to contribute to the secretions. Okay, so it is going to increase the distension further, and it's probably going to aggravate the whole situation. Now, oral feeds. What do you think about oral feeds? Do all patients with bowel obstruction have to be kept completely nil oral? Your thoughts? In palliative care, you can give, so okay, Harishankar is telling me oral hydration solutions can be given. Okay, so you can give sips of hydration, okay, and try not to give solids because that's going to be difficult. So liquid based sips can be given. What about total parenteral nutrition? Total parenteral nutrition? You go for a home care, you see this patient who is having a malignant bowel obstruction because of an advanced cancer, and he's not been able to take in anything much. So what do you think? Do you suggest a total parenteral nutrition? Do you suggest a nasogastric tube? See, total parenteral nutrition is that where you probably could give a choice or an option if that person has a survival more than 3 weeks. Okay, if you think that person has got a good prognosis and a survival definitely more than 3 weeks, maybe you could consider total parenteral nutrition as a choice, as an option. Okay, so what else? Nasogastric tube. Nasogastric tube. Should everybody be put under a nasogastric tube? Yes. How does nasogastric tube help? It's for a particular reason that we put the nasogastric tube, right? We connect it to a bag and we keep the nasogastric tube there. And we keep the person nil oral. What is that for? This is for decompression. Okay, it's for decompression because there's a lot of distension happening there. So this is basically to decompress the distended bowel. Okay, and again, feeding jejunostomy. Having a feeding jejunostomy is probably going to solve the point of feeding the patient, but where is it finally again going to? Again, the feed that you're giving is going to go to the obstructed area itself, and it is not going to pass. Okay, so sips of fluid is good, and sometimes in very advanced patients, like I have had patients who are in the terminal phase, that they've been on NG tubes, and they've had this immense feeling to feel the food. They just want to taste food because they've been nil oral and all that. So sometimes if you take off the nasogastric tube and tell them, okay, it's fine, sometimes they might just have continuous high volume vomiting. So to kind of balance out the two sides, sometimes they have to be put on the nasogastric tube, and you have to tell them, okay, you can have minimal food, because if you have the nasogastric tube, it's just going to come out straight through that nasogastric tube into the bag, and the patient feels that he has had something, and that feeling is satisfied. So this has been done for patients who are at end of life. So now, having said that, I wanted to go through a case report, but I think time is short. I think should we just go through this? I will quickly go through this because this is all about what we have already done. So Sarah is a widower supported by her children living in UK. Okay, so she's 62 years old, and she's having advanced CA stomach with mets all over her peritoneum. She's already had a palliative distal gastrectomy and followed by chemotherapy. But unfortunately, what has happened after 2 cycles of chemo, it showed that she's having disease progression in her CT. So basically, she has vomiting and abdominal colic for 2 days, but was still able to pass some amount of stool daily. Now, Sarah had vomiting 3 to 4 episodes per day, which was unrelated to meals. So tell me, from the discussion we had, Sarah is now having disease progression. She is having vomiting and abdominal colic. She has vomiting at least 3 to 4 episodes a day, and it is unrelated to meals. What is the first thing that goes into your mind about what kind of obstruction this is? Upper. That's just wonderful. Okay, so right now you have been even able to diagnose without a USG, without an X-ray, without the CT. You have been able to find out where your patient has the obstruction by just the history, right? So that's excellent. So it's an upper level obstruction, and vomitus was bilious and partially digested food. And on examination, she was not dehydrated, and her abdomen was distended. Bowel sounds were sluggish. So if you're having a sluggish bowel sounds, what does it mean? A sluggish bowel sounds? If you're having a sluggish bowel sounds, it means that you are right. It's an incomplete obstruction. Okay, it's not a complete obstruction, because in a complete obstruction you would not get any bowel sounds, right? Okay. So next, what happens to her? An urgent CT is done. It shows a small bowel obstruction. See, they had to take a CT to understand that, but you didn't, right? So that's just great. In view of persistent vomiting, a nasogastric tube was inserted. Sarah was told that the nasogastric tube insertion would be a temporary measure for decompression. Okay, that's what they told her. As she was still opening her bowels, the impression was partial rather than a complete bowel obstruction, and the intention of management was to reverse the obstruction. So she was treated with what? Suppository, bisacodyl, regular interval of intravenous metoclopramide. Then she was also given dexamethasone, and she was started on fentanyl infusion for worsening of her lower abdominal pain from the peritoneal metastasis that had been present for the past 2 months, but now progressing. What happens? There is no bowel action. But so because there was no bowel action, IV perinome was increased on the next day, and she had a marked clinical improvement. And the NG tube aspirate also decreased, and she had no vomiting. So they pulled out her nasogastric tube, and they told her, finally, you can take it off. And they just put her on IV metoclopramide and dexamethasone for 2 days and stopped that also. But again, what happens? Sarah again starts vomiting. Okay, she has 3 episodes of vomiting, and that to moderate to large amount. And she was again started on metoclopramide, dexamethasone, and other IV drugs. And despite the above treatment, Sarah's symptoms persisted. So I want you to tell me what would you do? What would you advise for her? We'll make this quick because we have to start the case presentation. We are late by 7 minutes, 6 minutes. Yeah, I can't get the chat screen. What will you advise for Sarah? You can speak, if not chatting. What will you advise for Sarah, who's already had a complete obstruction? Yeah, so Kiruba tells me that it's not a complete obstruction, so she can go for surgical intervention. So she is at a point where she has been started on treatment, but yet it was not helping. They saw fast progression of the disease happening. So it seems to be a very tough disease. And she doesn't seem to be a person who has much support. She seems to be a person who does not like much interventions, because they had to promise her that it is just a temporary measure that the NG tube was put. So now you are at this dilemma what to do. So Parvati tells me that give antiemetics, give IV fluids. Okay, we can keep continuing that. Any other drug you would like to add here? She's having a large volume of vomiting. Large volume vomitus. Okay, substitute perenome with Ondim. Okay, right? But they didn't say that on giving metoclopramide or increasing the dose, the pain increased, right? But you could always add on another antiemetic. You need not have to completely stop it, but you could even add on another antiemetic like Ondim or haloperidol. Okay, now what else? Anything else you would like to add? How about octreotide? We discussed about it, right? Octreotide would be helpful in this. Okay, you could probably start her on octreotide, bring down the secretion so that she doesn't need an nasogastric tube, and probably counsel her on what she wishes, the family wishes, and give a good plan for her. So finally, what happened for her is that goals of care was established after discussing with patient and her family, and she preferred to keep the nasogastric decompression while she enjoyed taking fluid orally. So she would take fluid orally and she would keep the nasogastric tube still there so that, the decompression was happening. And they finally decided to stop the chemo and go for just comfort care. And she was sent for a home hospice support. Okay. So that's it. So now we all know what is the classification of intestinal obstruction. We know what are the symptoms. We know how to diagnose. We know how to manage and how to treat bowel obstruction in palliative care. Okay. And these are my references. And thank you.
Thank you, ma'am, for the wonderful presentation. If you have any doubts, please.
I think because we are running short of time, we might as well club it after the case presentation, right?
Okay, ma'am. So today the patient story will be presented by Sister Dixida Thapa. Sister Dixida, are you there? Dr. Vineetha, can you stop your sharing?
Oh, yes, yes, I will.
Dixida?
Dixita, can you unmute? from your end?
Yes, sir. Hello?
Yes.
Hello, can you able to see the slides?
Yes, ma'am.
Yeah, okay, you can present.
So good evening to everyone and namaste. My name is Diksha Thapa and I'm from Green Pasture Hospital, Pokhara, Nepal. So I'm working as a palliative staff nurse and I've been recently assigned here. So I'm just a beginner in this field. So talking about the patient detail, my patient is 27 years female who is diagnosed as a vertebral tuberculosis. So during the time of the admission, patient was presented with the complaints like inability to walk, with which result there was a spasticity present in the lower limb and severe pain at the left hip joint, constipation, abdominal distension, loss of appetite, and nausea. So, history of illness. Patient was apparently well before 2 years back. However, during third month of pregnancy, she suddenly developed fever, which would rise about 104 to 105 degree Fahrenheit on and off. She went to nearby medical and managed her fever. During her antenatal visit, she was also found to be anemic and thereby managed the issue as well. Later at the third trimester, she began to have pain in her left hip joint, which went up so extremes that she was unable to walk. However, due to poor financial background, she didn't manage the issue. So she underwent on vaginal delivery and gave birth to a healthy child. Her condition aggravated after this as she again developed high fever that would rise to 104 to 105 degree Fahrenheit. She could not even stand properly because of her lower limb weakness and presence of pain at hip joint, which worsened the situation. She also had one episode of tonic-type seizure, so was sent to tertiary healthcare and then diagnosed as vertebral tuberculosis. So she got treated with antituberculin drugs for 6 months. By that time, she could not walk, so got bedridden. In that process, she gradually developed spasticity in lower limb and had multiple bed sores of grade 3 and grade 4. Patient was referred to our hospital for the management of complicated bed sores and other symptomatic treatment. So on the examination, general condition, she was conscious and oriented, looks pale, tired, and lethargic, and she was also severely malnourished. Vital signs, temperature 98.6 degree Fahrenheit, pulse 80 beats per minute, respiration 18 breaths per minute, BP 90 by 60 mm of Hg, SpO2 98%, and the pain scale, she had 9 by 10. Bed sores, sacrum 4 grade, and left and right iliac rest 3 grade, and left and right malleolus 2, left and right greater trochanter 3, and right calf 4. And also later in the during the advancement of her disease condition, she lost the bladder function, bladder sensation. So because of that, Foley's catheter was done. So treatment and significant investigation. Her hemoglobin was found only 5 mg per dl, and for that, 3 pint of whole blood transfusion was done. WBC was found to be 12,000 per ml. X-ray, CT scan, lumbar puncture, and biopsy was done. So psychosocial aspects. She's a 27-year young adult woman, married with love of her life for 2 years now. She has 1-year-old son living with her maternal family. There's a poor coordination among the family members because she eloped. Husband lost his job because he's a primary caretaker, so they have no income source now. She's worried about her life. She feels burden for her husband due to the dependency. So medications, syrup morphine 0.5 ml for oral for hourly, tab PCM 1 gram for oral QID, tab pregabalin 75 mg for oral BD, tab amitriptyline 10 mg for oral HS, tab baclofen 5 mg for oral TDS, tab metoclopramide 1 cap for oral OD, cap multivitamin 1 cap for oral OD, tap pantoprazole 40 mg for oral OD, syrup lactulose 15 ml for oral TDS. The main concerns are about pain management, nutrition, constipation, nausea, and wound management. So in the summary, a 27-year woman diagnosed with vertebral tuberculosis with multiple bed sores who is emaciated and has severe pain. She cannot control her bladder and has bilateral lower limb weakness. She has poor oral intake because of nausea, and she is constipated at the same time. So my discussion points over these slides are how to encourage oral feeding to the patient, what can we do for the management of constipation, how to manage the symptoms of nausea in patient. So thank you.
Thank you, Dixita. We would like to hear from the participant side, how can we help Dixita for helping this patient? We have learned many things. Last week also we have learned how to manage nausea, vomiting, constipation and all. So either you can unmute yourself and talk, or you can chat. You can put your answers in the chat box also. Dixita, what is the pain score of the patient right now?
The pain score, it's like 7/10, and the patient has already been discharged. So,
Okay. What pain medication is going on?
during the discharge time, a syrup morphine and tap PCM.
It's syrup morphine. How long she got pain relief?
She she needed breakthrough doses in between during her dressing time, and otherwise that dose has she has controlled the pain. So.
Okay. And what about her constipation? Are she taking any laxatives along with the opioids?
Yes, yes, ma'am. The syrup lactulose has been added, and during her hospital stay, like easyvac enema has also been provided, and that she would pass the stool, but then still again she is having difficulty in passing the stool after that.
Anybody wants any clarification regarding this patient story? Any more clarification? Madam?
Yeah. Thank you, Dixita. It was a nice presentation. So here there are issues like the patient is having pain, the nutrition of the patient is compromised, there is constipation, and the patient is also bedridden and is on catheter and things like that. A lot of psychological factors. Now, the first question is how to encourage oral feeding to the patient. So I think we need to understand exactly before intervening on what diet to give. See, we've got a lot of very good answers here, small frequent meals, and repeated intervals and all that, antiemetics, syrup permethrin, distraction, environmental modifications to control nausea. So all these answers are coming in for about the oral feeding. I think we need to still further understand what exactly is the reason that she's not able to eat. Is it the distaste? Is it that she has total loss of appetite? Because if it is loss of appetite and loss of interest in things, we are looking at depression. If it is otherwise that, she feels hungry, she's not able to eat, we have to look at other factors. We do not know she's got multiple bed sores. Are they fungating bed sores? Is it the odor that is actually, making her unable to eat? Is she having any oral bed sores? Is she having any oral thrush, halitosis, mucositis? She is on ATT. She's on anti-tubercular drugs, right? So we don't know what is it. Is it any side effect profile of those drugs which is causing the nausea? Is she having a reflux symptom that she's not able to eat? Or is there actually anybody to prepare the food? Because now she is staying with her husband. And is there actually good support at home to prepare the food and give her? So all that is also a if she, and because she is bedridden, to support her well enough when she is eating. Or is it that she is actually bothered that every time she has to go to pass stools, her husband has to take all the trouble, so that in turn is making her eat less, so that she doesn't have to take trouble her husband more. I mean, these are all different things that we need to actually look into and talk to her about and find out, because we might not just catch these things by simply examining the patient. So otherwise, if you ask me, on the whole, definitely small repeated interval feeds, and again a high protein meal is very important for her because she is very emaciated. So we have to address that. And again, her on investigation, her HB levels are like 5 grams, and that's like really, really low. So she has to be on iron-rich food. That is also there. That is what I would want to talk about oral feeding, to whatever details are given for now. And what to do for management of constipation? Again, we need to understand what is the reason, probably why. Like I have seen personally myself, when I go for home cares, that deliberately the patient eats less, so that he has lesser bowel movements. So because he or she feels that they are burdening the caretaker. Yeah. So what if this lady was deliberately doing that, and finally it ended up as a chronic constipation and an obstipation? So that has to also be looked into. Again, you can manage it with, she's already on 15 ml lactulose TID. So probably that is not sufficient. We have to hike the dose. We have to combine it with probably stimulant laxatives like bisacodyl. That is what I also feel. And also look at her hydration status. Also look if she has other drugs which is causing the constipation. I mean, aggravating the constipation. Like she's on opioids. Is it the opioid which is causing the constipation? She is also on amitriptyline, which could also cause some amount of constipation. So all these things also have to be looked into. Which drug has to be continued, which drug has to be avoided or substituted with something else is one thing. And how to manage the symptoms of nausea in this patient? Again, I think we already went through that. If we have more, it would be better if she has more of prokinetics like metoclopramide, so that it could also help with the constipation. Yes, domperidone also. So these kind of prokinetic antiemetics would be what I would suggest for her, definitely, for managing her nausea and vomiting. And again, she probably has gastritis or gastroesophageal reflux because of the multiple medications that she's taking, because we just have the list of her palliative medications. But she is a person who is diagnosed with a vertebral TB and is probably still on ATT. We don't know. So that is another thing that I would want to add on. And I just wanted to know one more thing. Dixita, why was LP done for her, lumbar puncture?
Like to further investigate. It was not done in our hospital, but
Okay.
she came with all those investigations. But
Okay, okay. So this 5 gram HB is not her current investigation. This was like long back.
no, this one is the current investigation, but all the diagnostic measures, all she has done, it has not been in our hospital. It was
Okay,
already been done, and she came for the palliative care only.
okay. Because 5 gram hemoglobin is very low, right? That
Yes,
it warrants a transfusion actually.
yes, ma'am. It was like we checked her HB, and it was only 5 mg, so a blood transfusion was done. And
Yeah,
she was like before coming to our hospital, she was undergoing like a Paris tablet. She was taking that.
yeah. Okay. So, and was a rectal examination done for her?
That was not done in our hospital.
Okay. Another thing also is that because she's been on catheter for long, you
Mm.
also have to rule out urinary infection, because urinary infection also can present with pain, multiple bone pains, and also nausea. Um, need
Uh,
not necessarily have, the typical fever and all that. It could even present in a very bizarre way.
Before coming to our hospital, like she was treating in so many other hospital, and
Uh-huh.
there she was also diagnosed as UTI, and it
Uh-huh.
was already treated.
Okay.
And when she was here, she didn't have any UTI. And
Okay.
before discharging, silicone, like her catheter was changed into silicone catheter,
Okay. Okay.
and then she was discharged from our hospital.
Mhm. Now, why I was thinking is because her labs are also showing a total elevated count.
Yeah,
So leukocyte count was a bit high at 12,000, right?
yes, ma'am.
So I was just wondering.
Like
And
she has undergone so many treatment, and she was financially poor when like she was here, and
mhm.
because of the financial condition, like we provided enough financial support through our social service,
Mm,
and we could not further do that, and she and her family was also not financially supportive. That's
okay.
why she was not like okay for discharge, but because of the financial issues she has
Hmm.
to be discharged. That's why.
Okay, okay. Actually, I'm not quite happy with her medications.
Mm.
Does anybody among the participants have any thoughts on that? Could you all just could you keep it to that slide, and everybody could you just look at the different medications that she is receiving, and any comments on that?
Could add any laxatives, stimulant laxative along with the more opioids.
Stimulant laxatives along with opioids. Yeah, we have only lactulose here. That is one thing. Probably along with the lactulose, we might have to try bisacodyl also, a contact laxative, stimulant laxative. Otherwise, I was also looking at one thing, considering that she could be a person who is on ATT, which are hepatotoxic drugs by themselves. I was actually wondering, should we go with paracetamol 1 gram QID, which would altogether aggravate the or add on to the hepatotoxicity. So that is one thing that went through my mind. Then anything else that any of you felt, participants? You have amitriptyline, pregabalin. Okay, it's probably for the neuropathic pain that she was having. Amitriptyline also was for the neuropathic pain, but amitriptyline, I was just wondering why is it given at 10 milligram?
Like she also had the like complaint of not being able to sleep, and she would babble while sleeping.
Okay.
So that was another issue for her.
Now, one thing about amitriptyline is that what went through my mind is that amitriptyline is given only at 10 milligrams. So generally, if you would want to give it as a double benefit, like contribute to the neuropathic pain and also yet help her to sleep, maybe I personally, when I'm managing, I might have given 25.
Mm.
That is one thing. And another thing is that she has had a history of seizures. So you might just have to check, I mean, how safe is it to give amitriptyline for a patient with seizures? And again, metoclopramide was given as OD, a single dose. So that again, I was wondering why it was given as a single dose. She is a person who was really troubled with nausea and she was troubled with constipation. So probably I would be happier if her prokinetic antiemetic was round the clock, given at regular intervals 8 hourly.
Madam, if she is not getting adequate pain relief, why can't we increase the dose of morphine?
Yeah, definitely.
If there is any toxicity there, you can increase the dose.
Correct. 7 on 10 was her pain score that you were saying, right? Definitely we could hike up. The next step would be to hike up the morphine.
Like
And
during her hospital stay, 2.5 ml was given, and during the discharge time, it the tapered it in 0.5 ml.
was it tapered in the hospital itself, or when she was left, it was tapered and given?
When she was discharged.
I think that is where also another issue is, because whatever changes that we are doing in palliative care patients, it would always be nice to make the changes pre-hand, a day before the discharge at least, and see how comfortable they are on that, and so that we can send them home with that prescription. So they get some time, because these patients are not patients who can come often and meet us, or so it gives them more time.
Anybody
Right.
want to add anything?
Psychological issues have to definitely be addressed. You need a multidisciplinary team for her actually here, because it's not just the physician who is treating her and the palliative physician who is also doing the care continuum, or the palliative nurse who is regularly visiting her and advising her. Here, I think also major role is required for the psychological support of the patient, and also the PMR team, physical medicine and rehabilitation team, is to be involved in her care.
Yes, ma'am. Like she and her husband was both. They were both counseled by our counselor, and for her limb mobility and spasticity, or the occupational therapy and physiotherapist has been looking for her.
Okay. Okay. That's nice.
So I think
Yes.
along with the psychosocial support, you could assess the constipation history. So you can, if possible, you can do a PRE and find out if the patient is having constipation. Definitely loss of appetite will be there, and nausea, vomiting will be there, and also UTI. Madam, as like Madam said earlier, UTI. So if there is a fecal impaction there, so that fecal matters will compress the catheter, and the residual urine, the volume of urine inside the bladder, that will be the cause of UTI. So the important thing is we need to relieve her constipation. We can start the stimulant laxatives as early as possible, and if possible, you can do a PRE.
Yes, ma'am.
Okay. So, and I think we can wind up the session, madam.
Yeah. So thank you everybody so much. Even last session, and I think the session was even more better. All of you was so interactive. I really enjoyed today's session, and thank you, Team Pallium, for inviting me to be part of this program. Thank you all. Have a wonderful day. I hope you all learned something new today.
Yeah. Thank you, ma'am, once again. Thank you all.
Yeah. Bye bye.
Okay, thank you.